very happy to have here at ASCO with us Professor Bart Neyns from the University of Brussels. Professor Neyns, thank you for being with us. There has been a lot of talk about immune therapy here at ASCO. What are the studies that impressed you most?
I think the most impressive results that we've learned about at this conference were presented at the plenary session. And they complement data that we have learned at the AACR meeting. And those two results combined, they establish a new standard of care for advanced melanoma. And this is treatment with PD-1 blocking antibodies. So we knew that pembrolizumab outperformed ipilimumab. Today, here at ASCO, we learned that also nivolumab outperforms ipilimumab in the first-line treatment of advanced melanoma. On top of this, we just appreciated that there is still room for incremental activity, meaning that if you combine nivolumab, an anti-PD-1, with ipilimumab, the anti-CTLA-4 blocking agent, that you still can raise the percentage of response and progression-free survival, which is clearly indicating that there is still room to build on the current standards of and the molecules that provide us with success, ipi and anti-PD-1.
There has been also studies in other types of tumors than melanoma, lung cancer, for example. Can you comment on this?
I think the breakthroughs that we are witnessing in melanoma now also are becoming more visible in the setting of other tumors, and most importantly in the treatment of non-small cell lung cancer. Yesterday we learned that as a second-line treatment, nivolumab outperforms docetaxel in the treatment of such patients. In that setting, it should be appreciated that treatment with immunotherapy is more efficacious, less toxic, improves survival, yet that also there remains room for increment because we are not at the level of activity that is seen in patients with melanoma. But as mentioned, we should remain hopeful that also for these tumors there is room for improvement.
The tumor expresses PD-L1. Checking for PD-L1 on the tumor could be an indicator of efficacy. What do you think about that? Is it a marker?
Well, I think that it's complex in many aspects. First of all PD-L1 immunohistochemical assays are being developed as companion diagnostics. So when we try to compare the findings made for pembro with those made for nivo, we should be careful because they are not, the staining for PD-L1 is not performed with the same assay, and we are neither discussing the same cutoff values. So before PD-L1 would be considered as a biomarker that we can implement in daily practice, we need standardization. Most likely, these assays, as they are now being developed, may hold more promise for patient selection in tumor types where overall the activity seems to be more restricted to subgroups of patients. This could be true for lung cancer, but then again, as we learned yesterday, even if we look at patients which are PD-L1 negative in their tumor, there is no better outcome on more toxic chemotherapy, so it doesn't seem that we need to select in that situation. Also, if we look to melanoma, we now appreciate that if you consider the context of a PD-L1 negative melanoma, the activity of the combination of ipilimumab and nivolumab doesn't seem to be influenced by this biomarker. But still, there could be room to spare unnecessary toxicity. I think an additional breakthrough that we've seen presented at this meeting is the fact that it now became clear that patients suffering from tumors with a particular genetic signature, and this is MSI high, microsatellite instability high tumors, are tumors that respond very well to anti-PD-1 treatment. These tumors are for instance found among colon tumors, colorectal tumors. They represent about 15%, but we can also find tumors with this genetic signature of MSI high, for instance at the endometrium, the uroepithelium, gastric tumors, some brain tumors.
How heavy are the undesirable effects of these drugs? They always say it's manageable, but what does it mean for a patient?
With immune checkpoint blockade, actually patients tolerate these treatments extremely well. They don't feel anything until the body, which is in a condition where it can at a certain point start to experience inflammation, becomes sick. And what's most important is good patient education and rapid intervention. We have algorithms which are clearly established and can help us to guide our management of these immune-related adverse events, but we should be aware that they are difficult to predict during the course of treatment, and that we should try to intervene adequately when they arrive, because they are potentially very serious and even potentially lethal. But I do want to also stress the fact that in the phase 3 trial, even with the more intensive and more toxic regimen of Nivo and Ipi, there were no toxic deaths. So probably this also reflects the learning curve that we as medical oncologists go through, and that at least in with experienced physicians, one can handle these drugs with reasonable safety.
Okay, thank you very much for this interview.
My pleasure.
Okay. You wanted to